Okay, so in this lecture, we're going to cover cellular function, metabolic principles, and control. This is a really important lecture because most of what we do as respiratory therapists is related to meeting metabolic demand. The lecture today will cover some of the most important reactions that occur in our bodies involving metabolism and energy regulation, and therefore are important for us to understand as respiratory therapists because these are the reactions which we will oftentimes be dealing with in the clinical setting. So the lecture outline today, the first thing we're going to do is we're going to cover homeostasis. We're going to cover a principle called Le Chatelier's principle, bicarb transport. Bicarb is HCO3-. This is the chemical formulation of bicarb. Then we're going to discuss some applications of Le Chatelier's principle, including interpretation of ABGs. We're then going to discuss cellular metabolic pathways. That includes glycolysis and gluconeogenesis, as well as oxidative phosphorylation, otherwise known as cellular respiration. Now, there are a number of metabolic pathways, but we will only be discussing the metabolic pathways involved in energy regulation. Then we're going to discuss aerobic versus anaerobic metabolism. We're going to discuss lactic acid, where that comes from, why it's produced. Then we're going to move on and discuss blood glucose regulation. And then following our discussion of blood glucose regulation, we're going to discuss ketone body production, where ketone bodies come from. We're going to discuss a disease pathology called diabetic ketoacidosis, as well as hypercapnia. We're going to discuss hypercapnia in relationship to ketone body production, as well as its potential regulation of metabolic pathways in our body. Then we're going to finish with a case study. And hopefully this case study will tie in some of our discussion of the metabolic pathways. Okay, so homeostasis is a state of physical equilibrium and the tendency of a system to maintain inner stability. And so there are two examples of equilibrium that I would like to discuss. The first one is a static equilibrium. A static equilibrium can be depicted as a teeter-totter or a balance. Now, in a static equilibrium, the teeter-totter or the balance is displaced equally, such that there is an equal amount of weight on, in this case, the left side of the balance compared to the right side of the balance, such that no side is touching the ground. Now, these static equilibriums exist in chemical equations. And so this is an example of a chemical equation. The chemical equation is balanced such that the amount of reactants or chemicals on the left side of the equation are equal to the amount of products on the right side of the equation. And so in the example of this balance, or scale, or teeter-totter, if that's what you want to call it, if there is a greater weight placed on the right side of the balance, then the right side of the balance will be heavier than the left side, and it will subsequently tilt. In order to rebalance this, or reach a state of equilibrium, one would need to remove weight from one side of this balance, or add weight to the opposing side. The same thing happens for chemical equations. If there is an increase in the amount of reactants that are introduced to a system, then this chemical equation will readjust its proportion of reactants to products to create more products. So more products would be created. If this reaction is a reversible reaction, in other words, can go in the forward and reverse directions, and you were to add products to this equation, then those products would then be broken back down into reactants. The second type of equilibrium I like to discuss is called a dynamic equilibrium. And a dynamic equilibrium would be depicted as this picture containing two faucets. One faucet is adding water to a container, while the other faucet is draining that container. Now, the equilibrium that exists in this particular depiction is that the amount of water in the container remains constant. But if someone were to increase the amount of water being filled into the container, then this container would begin to increase in volume, and that equilibrium would no longer exist. Likewise, if you were to remove water at a more rapid pace, then the amount of water within this container would drain. And so this is a dynamic equilibrium because it involves the continual addition and or removal of, in this case, water. So our bodies are made up of chemical reactions, and all reactions have an equilibrium. Often we can calculate the equilibrium state of a biological reaction to determine if it's in an equilibrium. So the best application of these types of equilibriums is Le Chatelier's principle. And so if we take a look at the body's buffering equation, that's water plus CO2 goes to carbonic acid, which is broken down into hydrogen and a bicarb. Your body balances this equation such that the pH of your bloodstream remains within a normal range. If for some reason there is an increase in the amount of CO2 in somebody's blood, then this equilibrium that exists in this equation will become out of balance. And so what the body's physiological response is to do is to either increase or decrease the amount of CO2 within the system, or increase the amount of bicarb to compensate for that increased CO2. Alternatively, if the amount of CO2 in the system is decreased, then what your body will do is decrease the amount of bicarb within the system to compensate. And so an important component of these processes is that these equations are reversible, meaning that reactants can create products and products can create reactants. And so your body has the ability to consistently rebalance this equation. Now, some important components of bicarb regulation include the negative charge of bicarb. And so when bicarb is transported in and out of cells, in order to maintain, for example, the body's buffering equation within a cellular environment, as well as its extracellular environment, the charge distribution of bicarb crossing this membrane has to remain constant. And so because when bicarb is transported across a membrane, takes a negative charge with it, a negative charge has to then be transported back across the membrane into the cell to maintain the charge distribution across the cell. In other words, the same amount of negative ions outside the cell that are inside the cell. So in order to maintain that charge distribution of bicarb being transported to the cell, chloride is counter-transported into the cell. Likewise, if bicarb is transported into the cell, chloride is transported out of the cell. Okay, and this same mechanism occurs in respiratory tissues, in the lungs, the GI tract, and across all cellular membranes in your body. Another important regulatory process occurs in the kidneys. And so if you look at this picture, what I've depicted is a membrane containing type A intercalated cells that are depicted in blue. So here's one cell, here's another cell, and here's another cell. On the left side of this is urine in the collecting duct of the kidney. And then on the right side is an interstitial space, and then blood, the blood flow. And so this membrane right here would be considered an endothelial barrier. These types of cells would be endothelial cells. Now the kidneys play an important role in maintaining blood pH. They do that by regulating the body's buffering equation at this intercalated cell membrane. And so if hydrogen ions in this interstitial space become high, then according to Le Chatelier's principle, hydrogen will combine with bicarb to create CO2 and water. And that is ultimately transported into this intercalated cell. Now again, if you notice in this portion of the diagram, what you see is another depiction of the body's buffering equation. Ca right here stands for carbonic anhydrase. And then, so this water and CO2 are then broken down into hydrogen and bicarb. And hydrogen, through an ATP transporter, is ultimately secreted in the urine. Now, because the charge distribution across the membrane has to be equal, and hydrogen carries a positive charge, potassium is then taken into the intercalated cell, again to maintain the charge distribution in the cell. Subsequently, potassium is then reabsorbed into the blood, and bicarb is then excreted from this intercalated cell, transported across the membrane of this intercalated cell, again counter-transported by chloride to maintain the charge distribution in the cell. Okay. And so this is a mechanism in which your body regulates blood pH. This would be metabolic compensation to regulate high CO2 levels. And so if CO2 becomes high in your bloodstream, then your kidneys can utilize this mechanism to compensate. Likewise, if CO2 levels are low, then your kidneys can utilize this mechanism to compensate. And that compensation would involve either the retention or excretion of hydrogen ions. And so I think something to keep in mind is, although that this is one mechanism for regulation of metabolic acidosis or alkalosis, in other words, the regulation of the amount of hydrogen ions in your bloodstream, the kidneys only play a partial role in regulating blood pH. It's in fact a multifactorial process. I also want you to keep in mind that hyperchloremia or chloride levels can influence bicarb excretion. And you can see this counter ion right here is chloride. And so if somebody's bloodstream had an increased, elevated amount of chloride, then although chloride would transport into the cell here, chloride would also have to be counter-transported back out of the cell. And this would create what's called a hyperchloremic metabolic acidosis. In this case, in a hyperchloremic metabolic acidosis, bicarb would be excreted. So if we go through the different types of acidosis that you might experience, the CO2 is considered a respiratory component of this body's buffering equation. High levels of CO2 would be consistent with what would be called a respiratory acidosis. On a blood gas, the pH would be less than 7.35. The CO2 levels would be greater than 45. The PaO2 levels may be unchanged, and the bicarb levels would be within a normal range. Now, cellular compensation, or your body's compensation for respiratory acidosis, occurs in two steps. In the first step, cellular buffering occurs. This is buffering in the absence of renal compensation that was described in the previous slide. And cellular buffering can elevate plasma bicarb by 1 milliequivalent per liter for each 10 millimeters of mercury increase in PaCO2. This often takes minutes to hours. Renal compensation for bicarb reabsorption is the second mechanism that occurs, and that can elevate plasma bicarb by 3.5 milliequivalents per liter for each increase of 10 millimeters of mercury in PaCO2, and this takes usually between 3 to 5 days. So the ultimate expected change in pH with respiratory acidosis can be estimated by the following. In acute respiratory acidosis, the change in pH equals 0.008 times 40 minus the PaCO2. During a chronic respiratory acidosis, the change in pH can be 0.003 times 40 minus PaCO2. Now, these numbers are important to keep in mind because much of what we do in the clinical setting is about balancing the body's buffering equation, and about balancing this equation, and understanding the mechanisms by which metabolic compensation occurs for high levels of CO2 or a respiratory acidosis. And also remember that these mechanisms for compensation are essential for life, directly influences metabolism, oxygenation, and physiology. Now, a respiratory alkalosis, on the other hand, occurs when, for a pathological reason, the CO2 levels in the bloodstream are diminished. That would be the CO2 concentrations in the bloodstream. And so your body would compensate by reducing the amount of bicarb in order to rebalance this equation. And so during an acute situation, bicarb falls by 2 milliequivalents per liter for each decrease in 10 millimeters of mercury in PaCO2. And the limit of compensation would be a bicarb concentration of 12 to 20 milliequivalents per liter. These square brackets around bicarb mean concentration. During chronic compensation, bicarb concentration falls by 5 milliequivalents per liter for each decrease in 10 millimeters of mercury in the PaCO2. And again, the limit of compensation would be a bicarb concentration of 12 to 20 milliequivalents per liter. Then again, you can calculate the expected change in pH with the following formula. Metabolic acidosis occurs if there is a reduction in bicarb. If there's a reduction in bicarb and there's a metabolic acidosis, then oftentimes the PaCO2 levels are unchanged, yet the body's pH, blood pH, is reduced. It can be induced by two mechanisms: an inability of the kidneys to excrete dietary hydrogen, and an increase in the generation of hydrogen that's due to the addition of hydrogen or to the loss of bicarb. So your body can compensate for this via several different mechanisms. It can buffer with carbonic acid. To calculate the level of compensation, the Henderson-Hasselbalch equation can be used such that the pH of the overall system equals 6.1 times the log of the bicarb over carbonic acid. This would be the concentrations of both. The carbonic acid can be calculated by this formula. Carbonic acid equals PaCO2 times 0.03. And so this information can be gleaned from a blood gas, or an ABG, in which the values you obtain include the pH, the PaCO2, the PaO2, and the bicarb. The next mechanism for compensation includes intracellular and bone buffering. Hydrogen ions enter cells and are taken up by the cell and bone buffers. Those include proteins, phosphate, and bone carbonate. The next mechanism is respiratory compensation. If a metabolic acidosis occurs, it stimulates the central and peripheral chemoreceptors that control respiration. This results in an increase in alveolar ventilation. If there is an increase in alveolar ventilation, the concept, or what your body is trying to do, is reduce the concentration of CO2 such that this equation becomes balanced. The final mechanism of compensation involves renal excretion of proton ion load. Proton ions combine with the urinary buffers, particularly HPO4 or NH3, in the process of hydrogen secretion. Bicarb is then regenerated in the plasma. The next type of disturbance that can happen in this body's buffering equation is called a metabolic alkalosis. That's defined as an increase in the amount of bicarb. Now remember that bicarb is a base, and so an increase in the amount of bicarb would result in an increase in the pH. Compensation for this occurs via reducing alveolar ventilation, or through alveolar hypoventilation, in which case what happens is that PaCO2 is retained in the bloodstream in order to balance this buffering equation. Normally, PaCO2 increases by 0.5 to 0.7 millimeters of mercury for every 1 milli equivalent per liter increase in plasma bicarb. This compensatory response often happens very quickly because your body can alter its ventilatory response very rapidly. If the change in PaCO2 is not within the range that you would expect it to be, then a mixed acid-base balance occurs. Okay. When assessing for metabolic acidosis, there's a calculation called the anion gap that can be used to help understand the cause of the metabolic acidosis. The anion gap, or Ag, is calculated by adding the positive ions, that would be sodium and potassium, and subtracting them from the negative ions, that would be chloride and bicarb. The number that you get from this subtraction should be between 18 to 16 or 8 to 16 milliequivalents per liter. And that would lead to an average value of 12. The traditional normal range, if potassium is used, would be 12 to 20 milliliters equivalent per liter. And so this 8 to 16 range is applicable to equations in which the potassium is left out. Now what the anion gap does is it allows for the differentiation of two groups of metabolic acidosis. A metabolic acidosis with a high anion gap is associated with the addition of endogenously or exogenously generated acids. These would be acidoses in which you would not administer bicarb to. However, a metabolic acidosis with a normal anion gap is associated with the loss of bicarb or failure to excrete protons from the body. This type of acidosis would be treated via administration of bicarb because the underlying problem is a loss of bicarb itself. So what we just covered is Le Chatelier's principle and applications of Le Chatelier's principle determining ABGs. Now we're going to discuss cellular metabolic pathways. And so in this slide, what you see in this picture is a depiction of most of the metabolic pathways that we know about. If you look at this picture, what you notice is that there is no beginning or no end to metabolism. Every part of your body metabolism is connected to another region, those metabolic pathways. Now, when we refer to metabolic rate, the metabolic rate is the overall assessment of how quickly these reactions metabolize metabolites. In other words, how quickly these reactions metabolize reactants. Not all pathways are activated at the same time. And so while the metabolic rate of lipid metabolism might be upregulated at certain points in time, amino acid metabolism might be downregulated. And so, for the purposes of our class, and for the purposes of our discussion in respiratory therapy, we will define metabolic rate as the rate at which your body metabolizes glucose. Ultimately, your metabolism is where your body temperature comes from. An increase in metabolic rate signifies an increase in temperature. Now, another important aspect of this system is that metabolism is not linear. It changes, it accelerates, and it slows to meet the demands of the cell. And it also changes throughout the day. When somebody is sleeping, their metabolic rate tends to be slower than when they are active or when they are exercising. And so when you look at this diagram, and you look at the level of interconnectivity, we can ask the question of, does this imply a dynamic or static equilibrium? And the answer to that is that each individual reaction has a static equilibrium. However, the collective sum of all of these reactions is a dynamic equilibrium. And so your metabolism as a whole is regulated dynamically. Now, before we begin to discuss individual metabolic pathways, there's three important molecules that require introduction. The first one is ATP. ATP is a high energy molecule, and it's considered a primary source of energy for the cell. The reason why it's considered a primary source of energy is because it has 3 phosphates attached to it. Each one of these phosphate groups here, here, and here carry a negative charge. Because negative charges repel each other, when this chemical bond is broken, there is a force that's generated to push these molecules apart. That force that's generated is coupled to energy and energy metabolism. So ATP is a high energy molecule in your cell. The other two important molecules are FAD, and that has a positive charge, as well as NAD, and that also has a positive charge. The reason why these two molecules are important is because protons can be added or removed from this molecule. So that is that protons can be added to FAD2 to make FADH2, and protons can also be added to NAD to make NADH. Now, with the addition of protons is also the addition of electrons. So these molecules serve as electron shuffling molecules and will bring electrons to the mitochondria for oxidative phosphorylation. And so your body is designed to maintain the homeostasis, or a normal concentration of these molecules. Now, in this slide, what I've depicted is glucose, and this line right here represents glycolysis. There are several reactants in this glycolysis as well as several products. NAD+ is required in order for glycolysis to function. When NAD+ is utilized, NADH is generated. And so this NADH contains 2 electrons that are ultimately then shuttled over to the mitochondria, where they drop their electrons off at the electron transport chain. Now, in glycolysis, 2 ATPs are produced, and there is a final molecule that's produced at the end of glycolysis called pyruvate. Pyruvate subsequently enters the citric acid cycle when it is converted to acetyl-CoA. So pyruvate is converted to a molecule called acetyl-CoA. It is a 2-carbon molecule that enters the citric acid cycle. Acetyl-CoA then traverses the citric acid cycle. For every turn of the citric acid cycle, 2 carbons are lost. And this is where CO2 comes from. CO2 is exhaled. So for every 2 carbons coming into the cycle, 2 carbons come out for a net gain of 0 carbons. Now, in the citric acid cycle, NADHs are produced and FADH2s are produced. There's also the production of a GTP, which is equivalent to an ATP. It's a higher energy molecule. All these reducing equivalents all go to the mitochondria for oxidative phosphorylation. In oxidative phosphorylation, the mitochondria, ADP is converted to ATP, and so additional ATP is formed. And this requires an oxygen. And this is why oxygen is required for cellular survival. Okay, now if your body has low serum glucose levels, then the liver will draw molecules off of this citric acid cycle, combine them with a bicarb in order to create glucose. And so gluconeogenesis is the production of glucose, while glycolysis is the breakdown of glucose. Now, in the mitochondria, as I mentioned, NADH drops its electrons off at the electron transport chain. FADH2 also drops its electrons off the electron transport chain, except it does it at complex 2. Okay, and that does that right here. It drops electrons off at complex 2. And so if I take a step back and orient you to the electron transport chain, what we observe is that it contains several different complexes. Complex 1, complex 2, complex 3, complex 4. Now, when these electrons are dropped off at the electron transport chains, either at complex 1 for NADH or complex 2 for FADH2, electrons are then moved through this electron transport chain, and that's what these blue lines denote. As electrons are moved through this electron transport chain, protons are pumped across the membrane. And that would be the inner mitochondrial membrane of the mitochondria. And so to orient you to this diagram, this would be a cross-section of the mitochondria. depicted here, in which it contains an outer membrane and an inner membrane. Now this inner membrane space is depicted here, this inner membrane space is depicted here. The mitochondrial matrix, or the inside of that inner mitochondrial membrane, is depicted here. So protons begin to accumulate in this inner membrane space. Now, in order for electrons to keep moving through this electron transport chain, there has to be a final electron acceptor. And that's the purpose of oxygen. Oxygen functions as the final electron acceptor in the electron transport chain. And so without oxygen, electrons would not be able to flow through the different complexes of the electron transport chain. If that could not happen, protons could not be pumped across the membrane, and NADH and FADH2 could not drop off their electrons at those complexes. Okay. Now, in the presence of oxygen, oxygen acts as the final electron acceptor. Electrons flow through the electron transport chain. NADH and FADH2 drop their electrons off of the electron transport chain. The electrons flow through the electron transport chain, and protons are pumped across the membrane. Now, when they're pumped across the membrane, an electrochemical gradient is produced. There is a high concentration of protons in the inner membrane space relative to the inner membrane matrix. Because hydrogens have a positive charge, the inner membrane space has a greater positive charge relative to the mitochondrial matrix, which is relatively negatively charged. So protons flow across this inner membrane through a channel called ATP synthase. And the flow of protons through this channel drives the conversion of ADP to ATP. Okay. So without oxygen, the electron transport chain does not function, and NAD plus and FAD plus cannot be regenerated. Now, both NAD plus are required for glycolysis, and NADH is produced in glycolysis. It's also produced in the citric acid cycle, and FADH2s are also produced in the citric acid cycle. And so, if there is a high amount of NADH, according to Le Chatelier's principle, glycolysis cannot function. Also, if NAD plus is in low concentrations, then it is not available as a reactant. So glycolysis cannot occur. So under anaerobic conditions, there would be conditions without oxygen, your metabolism needs to find an additional way of generating NAD plus and FAD plus. In order to do that, your body takes the final molecule of glycolysis, pyruvate, and converts that to lactate. The purpose of lactate and the purpose of this reaction is to regenerate the NAD plus to allow glycolysis to function. Now, although fewer ATP, or high energy molecules, are produced in anaerobic respiration relative to aerobic respiration, it will allow a cell to survive for a period of time, depending on the extent of the hypoxia. Now, a byproduct of anaerobic respiration would be lactate, and that is an acid. So that does create a metabolic acidosis. The next thing we're going to discuss in this lecture is glucose regulation, ketone body production. In this diagram, what you see is epithelial cells that make up the boundary between the lumen of the GI tract and the bloodstream. As somebody eats dietary glucose, or glucose molecules that are within their diet, glucose is absorbed along with 2 sodium molecules. Ultimately, within this epithelial cell, glucose is then absorbed into the bloodstream through another glucose transporter called GLU2. When glucose is transported, the 3 sodiums are transported with it, and 2 potassiums are counter-transported. And so if somebody is hypokalemic or hypernatremic, this counter-transport mechanism might not occur, and glucose would be more difficult to take into the cell, or into the bloodstream. And so if you monitor glucose levels upon eating, upon the intake of food, glucose levels begin to rise. Then ultimately, after about an hour to 2 hours of eating, the glucose levels fall back down to a baseline level. Now, if you monitor a hormone called insulin, the levels of insulin mirror the levels of glucose, yet at a later time frame. And that's because insulin is a hormone that is required for glucose uptake into the cell. And so what's happening is that upon conditions that elevate blood glucose levels, insulin levels are subsequently rising to bring blood glucose levels down to a normal range by transporting it into cells for cellular metabolism to occur. One particular note that I want everyone to keep in mind is that people sick in the ICU often have higher serum glucose levels. That is a compensatory stress response. It does not mean that they are diabetic. And so insulin regulation and secretion occurs in the beta cells of the islets of Langerhans in the pancreas. Upon increased glucose levels, glucose is transported in to the beta cells, which is then subsequently metabolized for the production of ATP. ATP then shuts down a potassium transporter in the cell. Because potassium is not transported out of the cell, a voltage-gated calcium channel is opened, and this voltage-gated calcium channel allows the exocytosis of insulin into the bloodstream. And so GLUT2 has a relatively high affinity for glucose, and that's what Km stands for. So once the concentration of glucose reaches 5.5 millimoles or greater, this mechanism is activated. So in other words, upon elevation of blood glucose levels, there is release of insulin from the beta cells and the islets of Langerhans of the pancreas. Now, upon starvation or between meals, a hormone called glucagon begins to elevate. What glucagon does is it increases the production of glucose to allow the glucose levels in the bloodstream to remain at a baseline level. So upon the reduction of glucose in the bloodstream, less than 5 millimoles, glucose that's transported into the cell is not converted, glucose is no longer transported in the cell, and therefore it's not converted into ATP. So potassium channel activity is activated. That activates some sodium channels, and sodium channel activation leads to the secretion of glucagon, and that allows gluconeogenesis to occur. This transport mechanism is via a transporter called GLUT1 that has a lower affinity for glucose. Now, in the pancreas, you said that there's the production of insulin or glucagon depicted here. Glucagon takes stored glucose in the form of glycogen and converts that to glucose, which is then released in the bloodstream. It also increases gluconeogenesis. Insulin does the opposite. It causes glucose to be converted into stored energy, or glycogen. Insulin also causes fatty acids to be stored as fat, or glucose to be stored as a fatty acid. And it causes the production of proteins from amino acids. Glucagon does the opposite. It breaks down fatty acids and allows fats to be transported into the liver, be broken down, or utilize fatty acids for glucose. It also facilitates the breakdown of protein for the production of amino acids. These amino acids can also be utilized for energy production. And so if I place insulin and glucose on this diagram, what this diagram depicts is that while insulin stimulates glycolysis, inhibits gluconeogenesis, glucagon stimulates glucogenesis and inhibits glycolysis. Also, under starvation conditions, or under conditions in which glucagon is being produced, fatty acids are broken down in a process called beta oxidation, which then and the final product of the beta oxidation is that central molecule called acetyl-CoA, which can then enter in the citric acid cycle and generate NADHs. Alternatively, fatty acid breakdown in the liver allows the production of glucose. Again, because the final product of beta oxidation is acetyl-CoA, which is one of the starting molecules for gluconeogenesis. Now, if glucose levels are high, insulin is produced, glucose is taken into the cell, and then fatty acids are then created from glucose. Now, an important point to make is that humans cannot take fatty acids and convert net fatty acids into glucose. As I mentioned, at the last molecule in beta oxidation, or fatty acid breakdown, is a 2-carbon molecule called acetyl-CoA. Now that molecule combines with the citric acid cycle intermediate and a bicarb to create glucose. Now, as I mentioned earlier, as acetyl-CoA navigates this cycle, remember that acetyl-CoA is a 2-carbon molecule, and here 2 carbons are lost. There's a net gain of 0 molecules. And so, in order for your body to convert fats into glucose, in other words, take acetyl-CoA here and convert it to glucose, a molecule of the citric acid cycle is required. And once these citric acid cycle intermediates are depleted, your body is no longer able to convert acetyl-CoA into glucose. And so in order to replenish those citric acid cycle intermediates, your body breaks down amino acids and uses those amino acids to replenish these citric acid cycle intermediates. And so in the absence of amino acid breakdown, the conversion of fatty acids to glucose through gluconeogenesis is not possible. And so here's another diagrammatic reiteration of what I just discussed. Free fatty acids are broken down in a reaction called beta oxidation. The final molecule of beta oxidation is acetyl-CoA, then pulls off a citric acid cycle intermediate, combines it with bicarb, and creates glucose. In order to keep this final citric acid cycle intermediate in high concentrations, amino acids have to be broken down. If amino acids are not broken down, this intermediate right here is not replaced. If it is not replaced, fatty acids ending up as acetyl-CoA here cannot be converted into glucose. And so if somebody's body enters an extreme starvation state, in other words, a state in which that there is extreme breakdown of fatty acids, and this happens so rapidly that amino acids cannot be immobilized to replace the citric acid cycle intermediate, acetyl-CoA cannot be converted into glucose. Now, initially, as the starvation process initiates, as long as there is this citric acid cycle intermediate, that final citric acid cycle intermediate can combine with acetyl-CoA and a bicarb to create glucose. Now that utilizes a bicarb, and so under extreme starvation, there's often depletion of bicarb. But as these citric acid cycle intermediates are depleted, if amino acids are not immobilized, which is the case in an extreme starvation condition, as in a diabetic ketoacidosis, in which the body does not recognize glucose in the circulation and cannot transport it into the cell, then these acetyl-CoA molecules are still being created by fatty acids, and it cannot move in the direction of gluconeogenesis, and so your body converts them into ketone bodies. Basically creates different combinations of acetyl-CoA, which are known as ketone bodies. These ketone bodies are exported into the serum and serve as a less than optimal energy source, because the body's cells can utilize these molecules to convert them back to acetyl-CoA and hopefully allow other cells' citric acid cycles to be activated. Now, two of these ketone bodies are an acid. And so if somebody is a diabetic, is hyperglycemic, glucose is not taken into the cell, it is likely that diabetic ketoacidosis can occur. Ketone bodies will be produced. Also, if somebody is hypercapnic, then this CO2, being a product of the citric acid cycle according to Le Chatelier's principle, would inhibit citric acid cycle activity. And that subtle inhibition during starvation may lead to the production of ketone bodies. Although this is not as significant as a diabetic ketoacidosis, it may contribute to prolonged circulating levels of ketone bodies, which at a lower level in your bloodstream are considered safe. The last thing I'm going to do is cover a case study. In this particular case study, a 45-year-old male is found unconscious and unresponsive under a bridge. He does not appear to be well kept and may be homeless. He has a respiratory rate of 50 with deep labored breathing consistent with Kussmaul's respirations. The rest of his vitals are as follows. He has a heart rate of 110, blood pressure of 132/88, skin signs are warm to the touch, dry and flushed. His breath has an alcohol smell to it. And I want you to think about what you'd want to do, how you would approach this type of person. In a hospital, Blood tests reveal that a sodium is low, potassium is low, chloride is low, calcium is high, creatinine is high, glucose is very high, albumin is high, BUN is elevated, BMP is normal, he has a lactate of 1 and a hematocrit of 70. If you look at his ABG, his pH is 7.2, that's low. He has a PaCO2 of 32 and a bicarb of 10. If you calculate his anion gap, you notice that he would have an elevated anion gap. And so this presentation right here is consistent with a classic presentation of a diabetic ketoacidosis, including the breath having an alcohol smell to it. Ketone bodies tend to smell similarly to alcohol, especially in somebody's breath. And so that would be an important differential diagnosis when dealing with somebody who perhaps you suspect has drinking a lot of alcohol. Now, all of these labs are consistent with a couple of things. The first is dehydration. And that would indicate dehydration would indicate an increased albumin level, increased hematocrit, as well as an increased BUN and creatinine. In this case, the BUN and creatinine would increase because of kidney hypoperfusion. Okay, so the treatment of this would be to give fluids wide open. Would be to give him insulin and to provide blood glucose tests every 1 to 2 hours until he's stable, as well as serum electrolyte levels every 1 to 2 hours until he's stable. Now the fluids increase proton ion secretion through the kidneys, in addition to addressing a hypovolemic problem. And then you're also going to monitor his blood glucose levels, and you're going to maintain an airway and vitals. So a couple of notes on hyperglycemia. For each 100 milligrams per deciliter of glucose over 100 milligrams per deciliter, the serum sodium level decreases by 1.6 milliequivalents per liter. When blood glucose levels fall, serum sodium levels rise by an equivalent amount. Serum chloride and phosphorus levels are usually low in diabetic ketoacidosis patients. With a diabetic ketoacidosis, the anion gap is elevated greater than 10 milliequivalents per liter in mild cases and greater than 12 milliequivalents per liter in moderate and severe cases. Even in the absence of infection, CBC count shows an increased white blood cell count in patients with diabetic ketoacidosis. High white blood cell counts greater than 15 times 10 to the 9th per liter or marked left shift may suggest underlying infection. The BUN is frequently increased in patients with diabetic ketoacidosis. Plasma osmolarity is affected in diabetic ketoacidosis, and a plasma osmolarity greater than 290 in patients is frequently observed in patients with diabetic ketoacidosis. If the plasma osmolarity cannot be measured directly, you can calculate it with the following formula. Okay, and that would be 2 times the sodium plus potassium plus the BUN divided by 3 plus glucose divided by 18. Okay. And then patients who are in a diabetic ketoacidosis who are in a coma typically have very high osmolarities, greater than 330 milliosmolarity units per kilogram water. If it's less than that, the patient's comatose, there might be an additional underlying cause. And so there are a couple different reasons for a metabolic acidosis. So diabetic ketoacidosis, a lactic acidosis, and a hyperchloremic acidosis. The diabetic ketoacidosis occurs because of failure to transport glucose into the cell. So treatment would include administration of insulin and fluids. The lactic acidosis occurs secondary to increased metabolic demand that's greater than immediate oxygen delivery. Treatment includes treating the underlying oxygenation or circulation issue. And hyperchloremic acidosis occurs because of excessive chloride movement leading to loss of bicarb. Treatment includes treating the underlying cause and giving bicarb. Then I list some references here, and thank you for your time.